So this week we're doing chapters 48, 49, muscular, skeletal, and neuromuscular. There's some pretty different diagnoses in here, and we'll go over some of them. Actually, some of you did this neuromuscular dysfunction, Duchenne muscular dystrophy, one of the most commonly tested of all the neuromuscular ones. There is a case study to do, there is a dosage question, a discussion question to do, and also, there is that dosage calculation worksheet. I understand that somebody couldn't download it. I will put it again in your announcements with the recording from today so that you will have it there, just to be sure. And if you don't get it from there, send me a message. I'll send it in a different way, whatever I have to do to get it to you. Okay. So, let's go into muscular, skeletal, and children immobilized in bed. And yes, we get children that have these really congenital abnormalities or this degenerative problems that require that they are on bed rest most of their lives. And it could be due to an acute illness, or it could be due to something that they were born with, and their body is just breaking apart as it gets older. The thing with the immobilized child, it's a child, it's an adult, it doesn't matter. You're going to do all the things to prevent the complications, the coughing, the deep breathing, the turning, the positioning, all of that stuff. It's the same. It's not going to change, adult or child. Not at all. It's just that you have 10 pounds in your hands and not 110 pounds to turn over or more. Okay. That's the only difference that we see. So we know that if we're not moving, your muscles are going to get weak. They're going to atrophy, foot drops, all of those things. Same thing happens with children than adults. We know that they need the nutrition to keep their calcium up for bone growth because children are still growing. And that's the difference between adults and children. And bone growth has to do with they're still trying to grow bones. So if they're not getting the nutrition, they're going to have that quote osteodystrophy that we've talked about, or crooked bones and bones not shaped the way they should be. We know the cardiovascular system, that's the heart and lungs, and that's the edema. Again, we take care of that by that coughing, deep breathing, and turning and positioning. Now, put a kid in a hospital bed, separated alone in a room for a long period of time due to some sort of condition that they're on. Can you imagine how that they would feel stuck in a room alone? And children love to be around their, as I call it, their buddies and them, right? They want their friends there. So we know if this is a prolonged period of time, children are going to act out. They just are. They're upset. They're angry. They don't want to be sick. They want to be out with their friends. They want to participate. And you're going to see depression, anger, and aggressive behavior. It just happens. Another thing that happens, especially if you have a congenital child that for life is going to be requiring long-term care due to immobilizations, osteogenesis imperfecta, brittle bone disease. That's something that, yes, you will be immobilized. Duchenne muscular dystrophy. As we get older, that progressive muscle degenerative changes are going to cause lack of mobility. So again, this is going to affect the whole family. They're going to need therapies and doctors and surgeries, et cetera, et cetera. So coping with this is rough for not only the child, but for the family too, isn't it? I know that the hospital I worked at, every single unit was given a specialty name, whether it's a cardiac ICU or 3 East used to be the GU floor and your kidney dialysis floor. So all your GU diagnoses are there. And because of that, you have these family groups that are run by the families where they get together and discuss the care of their child, and they offer solutions that some of them have found when you have a child that's just being diagnosed with something. That floor also had the diabetic children there too. So again, knowing where to buy insulins and the prices and all of these things, parent groups are amazing. So children, get up and go, 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 right? They don't even stop. They want to play, they want to win, they're competitive. So they are going to be having all sorts of injuries, whether they're soft tissues, bruising, muscles, stretching their tendons, ligaments, and all of these happen just by playing normally, or it could be if they are in an organized sports. Now, contusions or an ecchymotic area, a bruising, is blood underneath the tissue. Now, the one thing I will tell you is don't think that it's just a bruise and you don't have to do any further assessment. Remember that bruising goes down deep in the tissue, could be compressing blood vessels, decreasing blood flows distally. So, what is one of the assessments you're going to do with bruising, especially on an extremity, a finger, a toe? You're going to check distally, right? You're going to make sure blood flow is still getting there. Was it a crush injury? I've seen dressers' TVs falling on children, climbing up to get the remote control, turning the channel on the TV, and TVs come off and crush children. So a bruise could look just like a simple bruise, but it could be further, it could be deeper, and it could be causing more problems. So be aware of that. Now, dislocations. I think of dislocation, I think of the Downs child. You take the Downs child, put them on their back, both feet can go up behind their neck, and they're like, nothing happened. You're not going to do it anywhere close like that to me. I don't have that flexibility, but Downs children do. Remember, dislocations, when they pop out of a joint, you are severing blood supply. So, whenever there's a dislocation, if it's a Downs child with their legs up and their hip pops out, we've got to make sure that that joint gets back to where it needs to go as soon as possible. One of the most common of all dislocations is that nursemaid elbow. When you that little toddler, you take their arms and you swing them back and forth, their elbows pop and it goes straight. And it's a nursemaid elbow. It's the ligaments are so stretchable and malleable that that pulling in the arm pulls them out, and they need to go have a doctor quick. Just they do a little manipulation and it goes back to where it goes. So again, Down's children. It's another thing that we have to watch out for. And knowing that dislocations, we worry blood supply. Now, sprains and strains, I think these are worse than any fracture. I was a big sports fan. I was the captain of the soccer team, the basketball team, the volleyball team, the ski team, all of that. I mean, I was one of those. I had six brothers, so I better be a little bit active in sports, right? I tell you, a sprain is worse than any fracture. I still remember going up to spike a ball in volleyball, coming down on my ankle, and I could hear it crunch. I still can hear that crunch. So, a sprain is when you manipulate those ligaments and tendons and you stretch them to where they shouldn't go, creating some blood to be going in there. And that blood causes irritation and swelling, and it is extremely painful. So, how do we and how should we teach our parents and children how to take care of themselves if they have one of these sort of injuries? Well, the first thing is just to stop, which is rest. Stop. I know that when I still remember the last time I got up, spiked the ball, came down, and yes, I got that point, but I came down and I killed my ankle I was out for 2 games because of that. But immediately I got on my back and put my legs straight up in the air because that swelling is instantaneously. And then the coach came with an ace bandage and ice and we wrapped it up. So it's that rest it, ice, compress, and elevate it. Now, today, unlike many years ago, we do believe that sprains need some sort of splint, some sort of support on them for helping with the healing. So, rice, remember that. Now, fractures in children, very common. Kids, when they fall down, what do? They put their hands out, right? And what happens? Fractured wrists. Most common of all the fractures, whether one bone or two bones. We know that if it's an infant that has these sort of injuries, we know that's not normal. Infants have very soft bones. They shouldn't fracture. They shouldn't break that easy. And if they've broken, something's not right. This would be questioning abuse, okay? And yes, I've seen 3-month-old infants with child abuse where they had fractured skulls, fractured ribs, fractured femurs, 3 months old, okay? So it does happen. Be aware of it. And again, treat it professionally because I know when I saw that case of that 3-month-old and it was a twin, I will never forget that little boy because I protected him in the end. And that's always our goal. Child abuse, protect the child. So types of fractures. Normally the kids fall down, they break a bone, the skin's intact, and it's a simple or a closed fracture. They just take and put a cast on it, align the bones, and they heal. And kids heal pretty quickly. Now, the one that creates the most problems, I think, is the open or compound fracture. This is when the bone comes out of the skin. That means the bone has hit the environment and now it's up for infection, and you are worried about osteomyelitis with this one. So, open compound fracture requires IV antibiotics, not oral, IV. We need the big guns because this is staph. This is osteo. We need to protect that extremity, the finger, the toe, the arm, the leg, whatever it is, okay? There's other sorts of fractures, complicated. That's like a rib fracture that goes into a lung. So it's a bone fragment that damages an organ. I think that's a very good explanation of that. Comminuted, little small fractures. That means when you broke it, little pieces of the bone are inside the skin, and that creates a lot of irritation in there. And then there's a simple avulsion. The bone and the tendon pull away from each other. It rips it off. And again, it's like a really bad sprain, but the tendon's pulled away. It requires a lot more to get it back to where it was. Now, one of the things we worry about with children with their fractures is they're still growing, right? And school age children, those young school age children, are the ones that are on the monkey bars and they think they're monkeys falling down and they're hurting themselves, right? Well, our biggest concern is growth plates. And it's like at the ball of a bone. And the growth plate, this is where the bone grows so that the child gains lengthen the arms, the legs, the fingers, the toes, anywhere there's a bone. So if we get a fracture on a growth plate, what is our biggest concern? Well, if we don't line it up, it's going to be crooked. So always, always, always a fracture on a growth plate. And you always see it in the elbows, believe it or not. That's the biggest one I've seen, growth plate fractures on the elbow. They will require surgery, an open reduction, internal fixation to prevent any growth problems. You don't want a crooked leg. You don't want a shorter arm. You just want everything to be as straight as you possibly can. And that's why surgery. Now, another thing that happens with children is these fractured bones, and we've got to look at how long is it going to take for them to be in a cast. I mean, put a 6-year-old in a cast, and they're not going to be sitting that very long with that cast on. So the good thing about children is that they tend to heal very quickly. When we look at the neonatal period, which is the first 28 days of life, and this is significant with club feet, we can put casting on these children immediately at birth, as soon as we see club feet. And because they are molding so easily at this young age, we need to get it on quick. And then every week we change that cast to get those club feet, whether they're outside, inside, up, down, they're just ankles and feet are crooked. That's all it means, okay? We want them to be where they need to be so they can walk. Look at that. Neonate, within 3 weeks, we can heal something. So that's amazing. As we get older, it's 4 to 6 weeks, but look at the adolescents. Now we're going into 2 to 3 months. Probably me, it's 5 to 6 months at this point, right? Because my bones don't heal as well. So knowing the difference between the infant who heals very quickly, and as we get older, it's longer. So as we get a child in with a fractured whatever, yes, we're going to do an x-ray and we're going to be seeing the fracture. I have learned that children, even very young ones, they can understand the meaning of a cast, why it's there, why the pain, if you show them the fractured bone. They understand more than you really understand. It really, they go, oh, that's what happened. It broke. So yes, that's why you have that cast on and you need to keep it dry, et cetera, because it's part of the cast care. Another thing that we know that children that can't put weight on a foot or a leg, something's broken because usually they can put their toe down. That's a sprain, but a break, they're going to put no weight on it. So almost guaranteed there. So a goal of a fracture is you want to reduce the mobilize and you want to keep the function and prevent deformities. That's it. Checking neurovascular signs, big nursing care. So we're assessing. Now, there's a picture. Yes, this arm is bizarre. It's like the most bad it could be if we had a cast on and never checked it, checked neurovascular signs. It can go that black. It can get necrotic. That's the point I make here. So knowing that, we're going to check this 6Ps. Important concept here. You're going to check for pain. You're going to check for pallor. It's getting pale. Something's going on with blood circulation. Pulselessness. Oh, that's absolutely blood circulation. Paresthesia. No blood, no nerves. It's getting very numb now. And then paralysis. Now I can't move it. And then swelling. So these 6Ps are what we will be evaluating fractured anythings for. So casting for fractures, with kids, we make it funny. I know I worked at a children's hospital and we had all different colored casting material from red to green for Christmas to orange and brown for Thanksgiving to, of course, your red for Valentine's Day and then any sports color, rainbows. You're going to have the army khaki colors and all sorts of colors, pinks and blues and greens and blacks. And, this actually makes it more fun for kids. It's a distractor, isn't it? Let's put on a different colored cast. And all right, you like the Miami Heat. All right, you're red and black now. Those were both the original colors. So again, you see this girl, she's got her little doll with the same colored, casting on. And again, that makes it less of what it really is. So casting, knowing how do we take care of it. The big thing is keeping it clean and dry and doing the 6Ps, checking for any pressure, pain, paresthesia, or immobility there. Again, nothing inside. A cool air dryer can sometimes get the itch out in there, but nothing in there because you can rip the skin open. Now, sometimes you don't need a cast. Sometimes it's a femur bone. And that femur bone, when it fractures, the muscles pull the bones not right next to each other. They sort of go angularly. And those little sharp edges hit the muscles and create severe, severe muscle pain and spasms. So the bottom one, it's called Buck's traction. It is a weight and a pulley that goes on the end of a bed. It's skin traction. It pulls the skin and it pulls it straight. It pulls those bones out so that the muscles are not getting, tickled by these sharp points from these bones. Okay. So it pulls it out. And that's called Buck's traction. What does these sort of tractions do? Now, we also have cervical traction, we have halo traction. These are different ones I'm showing you here. So when we have a fracture in a bone, the muscle tends to get weakened and it gets spasms and it creates a lot of pain. So let's put the muscles in proper position, and it relieves all of that uh, extra spasming and pain in there, and it will relieve, stop any sort of deformity because now you have it straight. So this is to keep it straight and to relieve the pain. So there's Buck's traction, Russell's traction, and Bryant's traction. Russell's traction and Buck's traction are both the same type of thing, and it's used for fractured femurs. Russell's traction just adds just an extra piece that covers the thigh, but they both pull the femur straight so that the bones are approximated, relieving all of that pain from muscle spasms until they can do surgery. And they put a metal pole right down the middle, a rod down the middle of the femur, and now it will be straight. And then they'll heal through therapy with that. That's a different change in practice from when I started nursing. They were in this Buck's traction, but they did more skeletal one with a diamond pin for a month. They would have these children in these get-ups. But today we do surgery a day or two after, a little bit swelling go down, we fix it. Now, Bryant's traction is one that you need to know, and this is for hip dysplasia that does not heal with the normal, that little pelvic harness. And I'm going to go that pelvic harness in a second and show you what it is. But this is Bryant's, your older children. You cannot be over 30 pounds. If you notice, the buttocks are a little bit off the bed and they're pulled at a 90-degree angle. Okay, that 90-degree angle pulls them up, and again, it keeps the hip sockets in the hip joint, and that will help with the healing. Okay. Another thing we could do for fractures is something called distraction or an external fixation device. We use this for really bad fractures. Sometimes we use this to lengthen a leg, lengthen an arm when an arm or leg gets too short, and they can make the bone make more bone and make it grow an inch or two. So this is another one. This one, we have to treat the pins, right? We've got pins in the skin, so pin care would be very important. Children can be born without a leg, or they can be born without parts which require amputation. I had a friend whose daughter was born and didn't have a fibula on the lower leg. So they had to take the lower leg off. So she had a below the knee amputation, and she had her prosthesis. And I'm telling you, when she met my children, she used to run around with a prosthesis and try to beat them over the head. And she was 4 years old. She was the cutest little thing. And that little amputee, she didn't care. You know, she got this leg to beat everybody up, going up and down stairs quicker than my kids. So she didn't know that she was different. And I loved that. And she was able to be mobile because without that prosthesis and that leg being amputated, she didn't have the ability to stand up and walk and run. So again, pretty cool. So sports participation, kids love competition. They love it, and they'll do anything to win. If you've ever watched them, my 8-year-old grandson, oh, that kid will do anything to win a game. He's like the biggest competitor. He doesn't care if it's rough, the physical demands, get up, go, and he's full out on speed, full out. Doesn't know how to slow down. And that's kids, especially school-age children. Know that because the way they get up, go out, they don't warm up, there's going to be injuries. They don't put on their equipment protecting them. All of these things increase injuries in children. Another thing is that overuse syndromes. You see this a lot with children trying to get prepared because they want sports scholarships, right? Or what about that gymnast who is preparing to go to big competitions? They do the same moves over and over again. All of those things can cause what we call overuse syndromes, little micro traumas, mini sort of sprains and strains. And here's that developmental hip dysplasia. So we saw that Bryant traction that we can use for older children, right? You can see how that hip can be in the joint. It should be here, but these kids somehow it's up top. That joint wasn't born in the joint sac. So if I'm taking this joint, bringing it up, that leg is going to get shorter. So you're going to see a short leg on the sides where that hip is not in the joint. And you're going to look at the gluteal folds or the butt cheeks. One's going to be higher than another because of where that hip is going to be. You're going to hear clickings. You're going to see positive ortolani, positive Barlow's, that short limb. And how do we treat this? Well, ever see a doctor, a pediatrician on the first visit with a newborn baby? In a male, they'll check the testicles, right? In any baby, they're going to take the knees, put them up, bring them down, and they're listening for that clicking. They're listening to make sure that that hip joint is in that hip socket. And when it's not, what they'll do is they'll place on that picture there is called a Pavlik harness, and it's for abduction. You need to remember that it's abduction of the hip. So it keeps that joint sock into that where it needs to be. And usually that isn't all it needs. Now, as I said, sometimes it's not enough, or we didn't catch it earlier enough. Now the muscles are all tense. We can't loosen them to get that joint sac back where it needs to go. Either they will put them in the Bryant traction or they'll put them in a spica cast. That's the other solution to it. And then older kids, because everything is so cemented in there, they've got to do surgery. They need to do tenotomies, osteotomies, or holes in bones and tendons to try to stretch them to get it back where it needs to go. So hopefully it's the Pavlik harness with abduction of the hip. And then maybe Bryant traction, their little butt cheeks off of the bed and they're at a right angle, and that will hold them up there also and put it back. I've mentioned it already regarding neonates and club feet. So they're born with this. Now, there's 4 different types. You don't need to know what they are. What you need to know is club feet is that the ankles are born in, out, up, down, somewhere. They're not in the normal place where they should be. So remember those first 3 weeks, those 28 days neonate, we can get them fixed in the first 2 to 3 weeks if we put on casts on these children. Now, Ponseti is the name of the way that we can fix this. It's called the Ponseti method, which is casting. And if you look at the cast here, we put on 1 cast every week. They heal that quick. You must do it every week. You can't let them on for a month. No, because they're healing quick. You want them to go back to normal within 3 to 4 weeks at minimum here, and you can do it. As these children grow older, you have to have their feet checked by podiatrist, orthopedic, right? Making sure that their feet and their the way that their posture is all good. Do they need a special shoe? All of those things that they'll be looking at. Now, I mentioned it earlier, it's something called osteogenesis imperfecta. I've seen 2 of these cases, one more severe than the other. And then I've seen some of these children in their wheelchairs riding up and down the halls, beeping their horns, going to the cafeteria during the day, because usually these children end up in wheelchairs by the time they're adolescents because of the amount of fractures that they get. Just changing a diaper Just lifting them up can cause fractures on these children. Changing a bed on this child, I would have a baby blanket underneath. I'd have a nurse holding one side, me the other, picking them up. So we could change the underneath. You don't just hold them because it can crack ribs and arms and legs. And the whole thing is not to break bones on them and to try to keep them in a position where they can be in a wheelchair and at least move around because mentally they are very alert. Their bodies are not, but mentally they're there. So again, we want to be careful of that fractures and keeping them in a way that they can be in a wheelchair and move around, okay? There is supportive care. There's no cure for it, but maybe some IV biphosphonates therapy, but basically is just preventing fractures. And if they do fractures, keep them in a workable position so as they heal, that they'll be able to still be mobile in some manner. Leg calf Perth disease. This is an aseptic necrosis of the femoral head. Did you just hear what I said? Asepsis. So there's no infection, but the head of the femur is dying off. So we don't know why. It happens. So how do we take care of this? As you can see, it's males ages 4 to 8. Sometimes it's both hips, sometimes it's just one. But what all of a sudden we start to see in these children is now, initially, they'll start complaining that they're like stiff or they're limping when they wake up in the morning, especially. You know, they get up and like it hurts and they take an x-ray and they'll see that the femoral head is like fuzzy, as I call it, because you can't, you'll see it's not this big round thing. You can see where it's just fuzzy and it's not at this level as the other side. So rest is what we have to do with these children. So bed rest, no weight bearing, NSAIDs, ibuprofen, anti-inflammatory is what they need. We might have to put them on that that traction for the femur, right? Let's pull that bone away. Let's give it some space for the blood to get in there and put blood supply back into that femoral head. So rest, maybe that home traction, and steroids. And of course, anything with bones, you've got to make sure nutrition is where it needs to be. Good protein on bone problems, right? Now let's look at 3 different problems with the spine. Kyphosis is what we call that hunchback. It's the upper spine. Lordosis is the lower spine, where you sort of lean backwards. It's like this inward sort of curvature. Scoliosis. Scoliosis is the one that they love to test you on. Scoliosis is an S-shaped curvature of the spine. Now, if you look at the curve, look at what it does to the one place where the lung should be. It smooshes it over, right? This is our concern with scoliosis because it's impeding on the space where the lung should be. So you can't take big breaths on, this would be the left side of this girl, the way this looks here. So we try to decrease that swelling. Now, this happens a lot at that pre-adolescent growth spurt in adolescence, which is at puberty, right? That's that 2 to 3 years, that's 12 to 15 area where they're growing quick. This is where we start seeing scoliosis. So what we start to see is they're bending over and one arm is longer than the other. We're starting to see that clothing looks really strange because of the way it's pushed over. Breathing could become a problem with this too, right? So what is our treatment? Well, depends on how bad that curvature is. Now, if that curvature is 40 degrees, we're going to have to put this child on an exercise routine. Is it above 40 degrees, 45, 50 degrees? This child, as much physical therapy you do, it's not going to be enough to relieve that curve so that the lungs can breathe. So at that point, it would be a surgical intervention. And one of the names, we could call it a spinal fusion. We could call it Harrington rods or Lukey rods. They attach the metal rods and try to straighten up the spine as much as they can. Medical treatment is these braces. These will be placed on this child 23 hours a day. And you put a cotton shirt underneath just for rubbing and for sweating. They take it off 1 hour a day to basically change, take a shower, and put it back on, and physical therapy to strengthen their muscles. Osteomyelitis, we've mentioned it a couple times in a couple different ways. Osteomyelitis, what do you see? Well, usually if it's a bone, where was the area where that bone was sticking out? A lot of times it's a toe or a finger, is where I've seen it a lot. And you see that toe is swollen and red and painful. You do a CBC, the white count's elevated because there's a staph infection brewing like crazy in there now. Okay, so white blood cells are elevated. Do the x-ray, we might see some little, fuzzy stuff around it. And how do we treat it? Well, again, this is an infection of the bone. It needs proper nutrition in order to feel better. Also, it's going to be needing IV antibiotics. Now, the antibiotic used on this usually is for staph, which is vancomycin. And vancomycin is one of those aminoglycosides. Remember, we have to do peak and trough levels on this one because you're concerned about kidney damage, also ototoxicity, hearing damage. So we need to be very aware of that. Teach our parents for having problems with decreased urine output or for having problems with hearing. These are things we really need to be aware of because that would be a side effect, okay, of that long-term antibiotic administration. And again, high protein, we need good nutrition. I mentioned Ewing sarcoma here because it's a bone cancer. The bone gets cancer and it grows. I mean, we try to radiate chemo and remove it if we can, but many times it's already metastasized. Now, JIA, which is also called juvenile rheumatoid arthritis, this is a condition where the body attacks its joints. It is extremely difficult to diagnose. I mean, most of you know I have rheumatoid arthritis. It took me almost 8 years to be diagnosed properly. They kept telling me all these different things. I kept saying, no, it's not. I went to, I think, 4 or 5 different rheumatologists when they found a test that worked for me. Oh, yeah, you really are JRA. I'm like, I've been saying this for a long time. So JIA, what's the big deal? My joints are being attacked. So let's look at what side effects, what are symptoms that we're going to see. Well, if your joints are being inflamed and attacked, whenever you don't move for a while and then move, whether you sit down, watch TV, try to get up, go to bed at night, get up, you're going to be very stiff. I know when I try to get up after class, I got to stand up and just slowly just work it out so I move. All right. It's just what it is. Another thing, some children, depending, could be in the hips, the knees, they might limp. You might see that joint swelling or disfigurement. And I've got a big picture of an eye here. And you're like, why the eye with joints and rheumatoid arthritis, juvenile idiopathic arthritis? One of the side effects is called uveitis. Their eyes get all bloody and the uvula gets all inflamed and it could affect vision. So these children do need eye appointments, okay? Uveitis is something with JIA. So Again, diagnosing it is hard. There's really no definitive testings. I mean, yes, we could look at all of the inflammatory factors, the STED rate, the C-reactive protein, ANA, rheumatoid arthritis factors, but one doesn't make it all. And it doesn't mean because this is an elevate and this is that, it is what it is. Again, it's looking at the whole pictures of what it is. Treatment, we know there's no cure. We have to decrease the inflammation because we want to preserve function, prevent those deformities, and let's take away some of the pain of that swelling that's going on there, right? So NSAIDs, perfect thing used for pain. For those acute moments, we're going to have a steroid, decreases inflammation, and it does work, but you can't be on it all the time. And then methotrexate can help. Also, some sort of biologic. I think it took 8 different biologics to figure out which one worked for me. So you can see frustrations of parents and of children when they're not getting that relief because not everything works on everything. You got to figure it out. Humira didn't work for me. Cimzia didn't work for me. I took one of them, an infusion called Remicade, very, very old biologic, but it gave me psoriasis. And it's used to treat psoriasis. So again, I have psoriasis. I never had it before because I'm being treated for rheumatoid arthritis. And that's part of this whole thing. So, what do we need to do for these children? What teaching? Well, of course, we want these kids to be normal. Treat them as normal as they can be, right? I will always tell you swimming is an amazing sport for rheumatoid arthritis because you are weightless and you're moving your arms and legs, and especially if you like water, great thing to exercise in. So, keeping your body moving with physical occupational therapy, using the NSAIDs or whatever you need to do for pain relief. And then, of course, overall health, getting immunizations, keeping healthy. Use heat. I hate heat. Give me cold, but heat, cold, whatever works, that's what should be used. Now, lupus is just like JIA, but it doesn't attack joints. It attacks your body. It attacks some of the joints, but basically attacks anything, the skin, your brain, your heart, your kidneys, anything, any organ it does attack. We see this a lot in those young adolescent girls where we start to see it. We know triggers could be that hormone that, going into um, getting their menses and going through puberty, and or it could be stress, or it could be overwhelming infection, sepsis. All of those things can cause it. Now, one of the organs it can affect is the face, that skin. And the skin, the rash can look like anything. I've shown you a couple different types, anything on the face like that, we could say that's lupus. It does get nausea, vomiting, diarrhea, pain, that weakness. I think it gets to the point where they see the arthritis, they see forgetfulness going on in a seizure, and then they come in for figuring out what's going on. And then they find out it's lupus. And treatment is steroids and maybe a biologic on top of that. One of the things that we need to teach our lupus children is that sun can cause outbreaks of lupus. So, Kirsten is 10 years of age, sustained a fracture of the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what? What is an epiphyseal plate? What's the problem here? Anybody know what an epiphyseal plate is? It's your growth plate. What's our big concern if you have a fracture of your growth plate?
Future bone growth can be affected.
Absolutely. So this is the one that gets open reduction, internal fixation, goes to surgery to make sure those bones are approximated. They put a metal plate, screws, and get it all lined up so that they can grow and they can grow without a crooked leg. All right. I actually had a chance to split these up for you. So anybody, anybody want to win today? Jonathan does. Okay. How about you, Madeline, today? Yeah, maybe. All right, let's get going. Kahoo! Muscular skeletal. A multi. What is the priority for a nurse to assess following a cast application? What's our biggest concern? It's your six P's. So pulses, pain, movement, sensation, paresthesia, anything like that. And if we see a problem, if the pulses are gone, the pain gets more, or it gets pale and you don't see the color there, you can't move it, this is something you report to the doctor. Remember, there's compartmental syndrome, and we don't want that cast to tighten it up and make it look like that black arm that I had in the PowerPoint to show you, because it will turn that way. A multi. Patient teaching for a child with a fractured bone that's had a new cast applied. One of the things that, working in an ER with children and getting casts, especially I live in South Florida, one of the biggest things is that children, many times they fracture their bones and it's always right before summer break or right as summer break starts and they want to go swimming. And many of us have pools in our backyard. I have had children come in fractured arm, get a cast on. We teach them how to use a bag for showering, how to keep it elevated, use a hair dryer, not to use powder and lotion and all those things inside the cast. And they go home, put on their bathing suit, and they jump in the pool. So now we have a wet cast, and they have to come back and get a new cast applied. I saw one boy do it two times in the same day. I thought the mother was going to kill this poor child for keep jumping in the pool. What should the nurse monitor after a soft tissue injury? Soft tissue injury, ecchymosis, swelling. Was it a crush injury? The whole thing about any soft tissue injury is to do neurovascular checks. And you're worried about those distally, right? Is blood still getting down to the fingers, still going down to the toes? Yes, neurovascular, most important thing, circulation. A fracture that penetrates the skin is called, it is called a compound fracture. Okay. That's when the bone comes out. What's our biggest concern about a penetrate the skin or an open fracture? It is infection, worried about osteomyelitis. A multi. Bryant's traction. Remember, that's the one that we use if Pavlik's harness doesn't work. It's used for developmental dysplasia of the hips. The hips aren't in the socket the way they should. They're up here a little bit. So it is for children less than 30 pounds. Over 30 pounds, it doesn't work. Skin traction for developmental dislocated hip, absolutely. It holds it up, tries to force them back to where they need to go in the joints. The hips are elevated and at a right angle. And of course, any traction, you always check skin for breakdown. What is a priority nursing care of a child with a compound fracture? Priority nursing care for compound fracture or a fracture open to air with our chances of osteo, your priority will always be IV antibiotics. Now, it doesn't mean pain medicine isn't in your other hand, but your priority is to prevent infections. Overwhelming sepsis can occur just from bone infection. It's a bad one. What is priority nursing care for a child who fell off the second floor balcony? If you have a child who's fallen off a balcony, our biggest concern is, are we going to fracture the spinal cord and create some sort of paralysis? Priority is keeping that neck and that body, immobilized. Absolutely. The second priority is keeping the child calm. Why are you strapping me down? They tape actually the forehead to the boards, and they put a neck collar on, and they tape these kids to those boards to keep them straight. It is scary. Principles of managing soft tissue injury include, what did I do immediately when I sprained my ankle? Tell you, it was a good spike. I got the point, but boy, did I kill my ankle. And we know when we're looking at that, it's going to be that rice. Rest, ice, compress, and elevate. We keep the swelling down, we keep that down, it's going to have a better chance of a quicker recovery. Epiphyseal plate fractures in children may what? Again, what's an epiphyseal plate fracture? It's all about bone growth. Very good. Thank you. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? So, peripheral neurovascular impairment, that means that blood isn't going where it needs to go. Capillary refill isn't there. It's getting pale. It's probably getting a little numb, and there's a problem. No blood flow going. So we need to immediately tell the doctor about an absent peripheral pulse because we need to get pulses down there quick so we can feed the tissue what it needs. A multi. How should the nurse care for the skeletal traction for a child with a fractured femur? So remember, it's skin traction, and it's a string that comes up over, it goes to a pulley, and there's a weight that hangs. And it holds those bones so that it decreases muscle spasms until they can get to surgery and have it completely repaired. You have to document the weight of the traction every shift. And we always keep them free hanging. We don't ever take them off for no reasons. We don't get them out of bed. No, these children, you remove those weights, that femur's going to go like that and create more pain again. You keep the weight on, keep the bone straight, and everything is in bed. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? So our action, what nursing care is always checking capillary refill every 4 hours or whatever the doctor's office told you to do or ordered. I mean, 4 hours is quite appropriate. What position do you put the legs of an infant with hip dysplasia? Which one did I tell you? And it is abduction. It's the word you need to remember. It holds those hips where it needs to be so that that hip joint can get into that hip socket and it can stay there. What statement by parents indicates more teaching regarding their 2-month-old infant with club foot? So you have an infant with club feet. What is the treatment? Remember, it doesn't matter what type of clubfoot it is. We know it's going to be serial casting. It's called Ponseti method. That's the other name for it. And you do it every week. You change the cast. You need to start it like yesterday because remember, neonates heal in 2 to 3 weeks if we start it quick enough. As they get older, you're going to have to do follow up, absolutely, making sure their feet are still sitting properly in their ankles. They might need special shoes. And again, every week, not every month.
The answer said that it was correct for every month.
Yeah, because that's what you had to correct.
Oh, sorry, I misread it.
It's okay. Osteogenesis imperfecta. What is it? That's okay, no problem. That's the type of question I put here just to tell you to be careful. It's opposite of what you think it should be. Osteogenesis imperfecta is something that, believe it or not, I've watched documentaries on it where they're not diagnosed at birth, and then the parents now are being charged for child abuse because they think all these fractured bones they've caused, but it's a condition, it's a disease on it. It is, everything's crooked, it is brittle bones, and we don't aggressive anything, these children. They need physical therapy, but very, very gentle because their bones do crack easily. What is pathologic cause of leg calf birth disease? What causes that late calf birth? That femoral head is all fuzzy there. What is that? So, late calf birth is ischemic aseptic necrosis. That means the blood stops going to the head of the femur. It's not due to infection, but it happens. And again, remember, treatment is rest and NSAIDs, maybe traction, and a good protein diet. Kyphosis. Which one is that? So kyphosis is humpback. That's that upper, the cervical spine. A multi. Which assessment indicates that an infant has developmental dysplasia of the hip? So that first doctor's visit at the pediatrician, he's going to take those legs up and down. What's he going to see? Remember that hip is up here. So we're going to see a shorter leg for sure. That's the asymmetrical leg folds, that positive ortolani. Everybody has a positive Babinski. It's not specific to developmental dysplasia of the hip, okay? And remember, moral reflex is that startle. That's infants at birth. They have that startle reflex. So that's not part of the assessment for developmental hip dysplasia. Lordosis is described as what? So this is the inward curve of the lumbar spine. You sort of like lean backwards. That lumbar spine is. You're also going to see lordosis with Duchenne muscular dystrophy. It's one of the conditions they have, the lordosis of the spine. Scoliosis is what? So scoliosis is that S-shaped curvature of the spine. That's all it is, an S-shaped curve. Adolescents with scoliosis that have up to a 45% of the curve of the spine would need to do what? So up to that point, what's the treatment? So up to 45%, they wear a brace 23 hours a day, only take it off to bathe, and physical therapy to strengthen the muscles in the back. After 45%, usually they're going to tell you things like 50%. It's surgical intervention. That would be the Harrington rods, spinal fusion, Lukey rods. They're different names, but they just try to straighten that spine. A multi. Teaching for a child with scoliosis with less than a 40 degree of curvature. What are they going to be having done to them? So brace 23 hours a day. You're going to wear a cotton t-shirt underneath, prevent any rubbing there. No lotion under the brace. I mean, you can go underneath, you can look, you can massage areas, but you're not going to have a lotion there or powder. And of course, physical therapy. A multi, a Pavlik harness. A little bit of everything. It's for those children with developmental dysplasia of the hip. It holds that hip in abduction. We're always going to check underneath that brace, making sure there's no irritation. And when the brace is off for that hour and we're bathing that infant, of course, we're going to be massaging those areas to making sure that there's good circulation. What is osteomyelitis? So it is an inflammatory condition of a bone and it's caused by infection. Remember, when we treat for osteomyelitis, yes, it's the antibiotics, but remember, it's also following labs, especially if we're using things like vancomycin and also promoting good dietary, which is increasing the protein in the diet. Goals for juvenile idiopathic arthritis includes. So the whole thing with JIA is to protect the joints and to reduce the pain and swelling so we keep a child mobile. What priority action should a nurse take to a patient with suspected spinal cord injury? So whenever you suspect anything with the spine, it's always immobilize the spine and protect it. I had a little 15-year-old boy came to me who slid into third base, and his head met the defender's knee, and immediately they heard a crack in the stands. He was helicoptered to me, trauma copter, and I was the priority, primary nurse for every trauma patient that came in that day. His right leg, he had no feeling, and his left leg, he had some left. So, spinal cord is there. I had to take that child to an MRI from the emergency room. We usually don't do that. So I had to make sure I was in charge of this child's neck and spine, which I was, and I was very vocal about it. Well, I got the kid up to the ICU. He had surgery. 2 weeks later, I went up to go visit him to see how he was doing because he touched my heart, making sure that these feelings would be coming back. So when I saw him, his left leg was completely back, and he had minimal weakness in his right leg, and he was being sent out the next day to therapy. He was going to have inpatient physical therapy, and 1 year later, that kid walked into my ER to give me a hug, to tell me he was perfect, he was fine, and he wanted to thank me. So, immobilization of spinal cord, always priority, because you might get a hug like I got a year later from that kid. Last question. Most common causes of spinal cord injuries are? So, any accidents, right? Motor vehicles, driving, sports, those are the kids. They're in everything. Jumping off of couches, jumping off of high places. Ashabash. Good job, Ashabash. Gayla. Good job, guys. Number one, Mariah. Good job, Mariah. And Megan and Lizzie. All right, let's go ahead and let's finish up with neuromuscular. We're doing actually very good on time. It's a good thing. So let's go back to our PowerPoint and go from there. So, neuromuscular. When you think of neuromuscular, you think of something with the brain that makes the muscles not work the way that they should. One of the biggest things that we think about, cerebral palsy. Cerebral palsy is what we call a group of permanent disorders of the development of movement and postures. It's usually caused intrautero, mom developing, these things happen. The most common of all the permanent disabilities in children, CP. Um, most up to most of the children can also have epilepsy with them. So you're always worried about seizures with these children. So, what causes cerebral palsy? Well, it could be just the brain wasn't made right. Could be a problem with the hypoxic moment, that vascular obstruction, right? Some hypoxia has occurred. Um, Premature infants, they have a lot of problems with brain being very fragile, the blood vessels, and they tend to burst blood vessels in the brain, causing strokes. And they do. They do have those same symptoms with the weaknesses and cognitive delays, etc. I think the biggest thing I see is that hypoxic anoxic episode where they're born and at delivery, they can't get out a normal delivery. They have to rush them to C-section, get them out, and they've had moments where they have been without oxygen. And that's where I see a lot of CP come from. So, spastic cerebral palsy, definition, you need to know this one. It's hypertonicity, poor posture, and difficulty maintaining balance. This is what we think of when we think of children with cerebral palsy. Again, why do we need to know all those developmental milestones for an infant? Well, this might be an infant that has very mild CP that we're looking for, right? We can have from very mild to very severe. So we can have delayed gross motor, abnormal motor performance, alterations motor tone, abnormal postures. All of these things can be all a combination of what these children's work with. So, what is our goal as a nurse? What do we want for these children? Well, again, we want them to be normal. We want them to be able to be involved with what's going on around them. So give them something to be able to have locomotion. Now, if you look at that picture, you see a kid on a tricycle. Well, I see more than that. I see a child who has splints on his legs, and I look at a child who probably has some mild CP of some sort or some neurodegenerative something. And we have given him the ability to move around on a bike. So we've given him locomotion. Isn't that great? Another thing is giving them the ability to talk when they cannot verbalize. Could be one of those little iPads. I've seen them on some little children. I mean, my little Jonathan, at where I used to do my clinicals at, that little child, nonverbal cerebral palsy. He was 7 or 8 years old at the time. I think he's 12 or 13 now, but he doesn't talk, but he has an iPad. And in that, he can show you what he's trying to talk about. And I think that's neat that this child, who years ago wouldn't have been given that opportunity, today has an opportunity to communicate. I think it's awesome. So with cerebral palsy, it's a lot of muscle issues, a lot of spasmings. So we need to put those foot ankle braces on so we prevent those foot drops and keeping those feet in proper positioning so that we can get them up and hopefully getting them walking, at least with a walker, if anything, okay? Any sort of spastic sort of abnormalities, we can release these spasms with surgery. Think about Botox. What does that do? that releases muscles where they don't want to release. Like all these little wrinkles in your face, let's release the little muscles so that we can smile without all of those the kinks in it. Well, we can do the same thing with muscles in the body. We can make them move easier without all that stiffness in there. Another thing with children with CP, as it was said, many of them do have problems with seizures. Again, a lot of seizure medicines can cause problems with their teeth. Think about phenytoin, Dilantin. It causes gingival hyperplasia. So making sure we brush their teeth and keep good dental care with them. And of course, we need to keep them stretched, physical occupational therapy. So CP, most of the kids, if we work with them, have some sort of ability to be mobile with ambulation, whether an electric wheelchair or with a walker, or some of them can walk with maybe just a cane or something without. It depends. There's all different levels of severity. But our management is giving the family and the child everything they need to be the best of what they can be, giving them medications to decrease the spasms. Also, safety is big. Think about a child who has problems with muscles and working their own muscles. Think about oral, eating, choking, gagging. Got to be careful, give it extra time to chew food, to sit them up longer, right? Because they will gag and choke on that if we don't. Also, giving them the ability to talk, whether it's speech through an iPad or doing it through their own mouth. Very important that we give them something to help them be able to communicate. And again, safety, safety, safety with these children. Now, neural tube deficit. We talk about the myelomeningocele here. This is a neural tube. Think about spinal column. Spinal column in a myelomeningocele is that the lower portion has been ripped up, pulled out, and is on the outside of the lumbar spine area on the baby. And it could be a little piece out or a big piece out. Now, it could be caused by many different reasons, okay, that this does happen. And it happens intrautero, and then they're born. Many of them we know because we've done ultrasounds and we see it. So when they are born, we have to know what to do for them. That's going to be our baby to take care of. So what do we do with this myelomeningocele? This is the spinal column and nerves and meningeal sac stretched and pulled out and born on the outside of the body. So we need to maintain sterility. So normal saline, liquid, keep it moist, sterile dressing. Let's protect the area, the skin integrity, so that when we close it, we've got nice skin. And these children, because of many, many surgeries and even many urinary catheterizations, because you're going to have decreased sensation to be able to urinate on themselves, these children are latex allergy from birth, before they're ever touched with a latex glove, because we know from our past that these children do get latex allergy extremely quick. So we don't even start it. Because of the nerves being pulled up from the lower extremities up and out, there's two things you have to watch: bowel function and urine function, because it's going to be deadened. Nerves are not going to be all there, okay? As I said, this might be the child that you do urinary catheterizations every 4 hours. Sometimes they can't do it on their own. This is also a child that might get that ventricular peritoneal shunt. I don't know if they still can regulate the cerebral spinal fluid between their brain and their spinal column. So this would be a ventricular peritoneal shunt, most likely. We can prevent a lot of these, and this was from your pharmacology, folic acid. We should know before we want to get pregnant, of course, all the time, we know that. not, but it would be nice that we started our folic acid at least a month before we wanted to get pregnant, and it does help decrease the amount of incidence of neural tube deficits. Okay, let's go into some of the muscular dystrophies, all right? This is probably the worst of all the muscular dystrophies. This is the Werding-Hoffmann disease, or floppy infant. These children are born and they can barely make a cry at birth. Progressive weakness, wasting of skeletal muscles, and these children, because their muscles don't work, usually die by before 2 years of age. So this child, we call it, they lie in a frog position. Everything is just weak, generalized weakness, as I said. They usually die before 2. Now, the most tested of all of the muscular dystrophies is Duchenne muscular dystrophy. Now, Duchenne muscular dystrophy is called pseudohypertrophic muscular dystrophy. It is something that mommy, an X-linked inheritance, gives to sons, and we usually find it between ages 3 to 7, and boys, not girls. We usually will see a child that is a little delayed cognitively. You're going to see their calf muscles, and sometimes even their upper arm muscles are hypertrophic because they're trying to use them and they tense so much, it creates this over making of muscles there. So it is hypertrophic calf muscles. And then this is a child who was walking or attempting to walk, who now is falling down and falling down. So it's progressively, he's getting weaker and weaker and weaker. Now, what is our care for muscular dystrophy, Duchenne's? Well, it's all about keeping the muscles as strong as we can for these children. So, diagnosing them again. Why is my child's muscles being continuously getting less and less? Well, we can measure muscle strength, and it's something called an electromyography, or an EMG. It is this little machine that produces an electrical shock, and it measures the strength of contraction that that shock produces. So if you have muscle weakness, you give a shock, and the response is not going to be as strong as you would want it to be, or it's overly exaggerated. So when these children are suspected Duchenne muscular dystrophy, this is what will diagnose it, that muscle weakness. Now, as I said, we're giving the muscles an electrical shock to move, to spasm. After this exam, many children feel like they just ran a marathon. So be prepared to give them some acetaminophen or ibuprofen. They're going to come back hurting because it does make all the muscles work on them. So remember that. This is a child that, because of muscle weakness, they have what we call a waddling gait. They really don't know how to walk, control muscles, so they'll be falling down a lot. Another thing they'll be doing is something called a Gower sign. And I do this all the time. You get on the floor and you can't get up. So you take your hands and you walk up your body to stand up, right? That's Gower sign. These children have it. As I said before, that lordosis, that curvature of that lumbar spine, hypertrophic arms or thighs, like I said. And as I said, that their mental impairment, mild to moderate problems with cognition on these children. And because they don't move that well, they tend to be obese. So we have to try to decrease that because this is a child's going to need full care. So there really is no cure. on this. What we try to do is keep the muscles as moving as best we can, but think about it. Which muscles are we concerned about with progressive muscles not working? The heart and the diaphragm. And that's what usually fails as a teenager and they die. These parents do need genetic counseling because it does come from mom. And if they want another child, they have to make the decision. Are they going to? Another condition, I don't know if you've studied it yet in your med surge, is Guillain-Barré. Guillain-Barré is a very interesting disorder. And I actually had a nursing supervisor who worked for me. She was 20 something at the time. And she came into the emergency room and she kept falling down. She didn't know what was going on. And she had been sick. She had a cold or something, like 3 or 4 weeks earlier, but just as falling down and just, couldn't control her legs. So Guillain-Barré is what we call an infectious polyneuritis, or an infection of the nerves, which start at the feet, where you don't feel your feet nerves, and then it travels upwards until it gets to your diaphragm, and then your diaphragm doesn't work. So if you have a child admitted with rule out Guillain-Barré, the one thing that you're going to monitor very closely is their oxygen saturations, because their diaphragm will stop working. They literally become paralyzed, usually from the neck down. Now, you heard me talk about the nursing supervisor who came into the ER. She was admitted to the ICU with Guillain-Barré. She ended up on one of those Rotarest beds and a ventilator and a trach. And she was there for about a month. And then all of a sudden, she started to breathe over the ventilator, because now it's going to go, all the muscles from the upper side going down to the feet are going to start to come back. So initially, I couldn't walk. Then I start being incontinent, constipation. Then I can't breathe. All right, then I can start to breathe again. Now I can start feeling my urine in my stool. Now I can move my legs, and now I can walk on my feet. That is what you see with Guillain-Barré. Ascending from the feet, going up, worrying about O2 saturations. So, treatment. Well, of course, we're going to have some sort of respiratory support. We need to monitor that very closely because we don't know when that diaphragm is going to stop working. We think steroids might work. We think IVIG might work, plasmapheresis. We're not sure. We try a little bit of everything to boost the immune system, but usually it does turn around. Another condition, neuromuscular, is tetanus. We've talked about tetanus, and tetanus is the other thing we call lockjaw, or the muscles in the neck get stiffened, which then all of a sudden it gets stiffened, you can't breathe, you can't swallow, and that causes respiratory distress. So, what do you see in these children? Well, there in tetanus was an entry point where the tetanus came in. Whether you were walking around, stepped it on that rusty nail, right? That's always what we hear. I stepped on a rusty nail and that caused tetanus. Remember, we need to clean that. Soap and water and antibiotic ointment. Remember, that still needs to be clean there. And then, of course, all that swelling and that tenseness upper airway, we know respiratory is going to go. We need to monitor for respiratory status. Treatment, tetanus toxoid vaccines. This is a condition. Many children die from tetanus. Okay. If we can get them past 4 days, they usually will make it. But this is an extremely, extremely ill child. Again, make sure you treat the wound, and IVIG that will help. Again, respiratory wise, they're going to go, right? So again, monitor the respiratory status. Fluid electrolytes, always, you don't want too much swelling on the brain on that. Make sure that tetanus toxide therapy is going on. And wherever that wound was, clean it with an antibiotic ointment, because these children get these severe neck spasms because of tetanus. It's so painful. We tend to just paralyze and sedate these children and try to get them over the hump so they don't have to feel all that joking and swelling in their neck. So, very sick kid. Another kid that we don't think about is botulism and honey. I've said it a few times. We don't give honey to children less than 1 year old ever. Some books say 2 years old because we don't know how it was bottled, how long ago it was bottled. We just want to make sure that we're not introducing anything that can cause a poisoning on them. So, infants. No honey or light or dark corn syrup. They use that a lot for constipation. In some cultures, they say, oh, give a little bit of Karo syrup, give a little bit of honey, that'll help. No, we don't do that yet. Very similar sort of symptoms that we saw with tetanus. Again, weakness, dizziness, headache, vomiting, and again, it's life-threatening respiratory paralysis. So we're going to be given again that IV botulism. And of course, because they can't breathe, we'll support it. And always, any child who's sick for whatever reason, we always have to maintain nutrition, whether it's tube feeding, hyper out, whatever, they're still growing. It doesn't stop because they're sick. And then the spinal cord injuries. I'll never forget my little guy who had his neck. And I'm telling you, it was C5, C6, and his neck was angulated. It was an impressive break. It was even more of a pinch than that picture down there. And it was scary to be the nurse in charge of his neck and his livelihood. And I'm grateful that the kid came out the other end and did very well, because outcome could have been different. We know spinal cord injuries, motor vehicles, always be. And that's that hyperextension flexion. That's that coop to coop where your head goes back and forth and your head gets shaken in cars. That's part of it too. Sports, I told you about my guy hitting a head on a knee. It happens. Think about birth. We pull heads out of there. That could be a problem. So, spinal cord injuries, number one, proper immobilization, priority, priority, priority. And then management of it afterwards, depending on what we find there. So, a progressive infantile spinal muscular atrophy, and the most common form of a floppy infant. Which one was it? Do you remember?
B.
How about C? How about C? Wording Hoffman's. So who would like to win the next Cahoots?
I'm just happy I got third place on the last one.
I thought it was pretty good. I'm running to the ladies' room very quickly. And let's go ahead and get started. Neuromuscular dysfunction. Goals for juvenile idiopathic arthritis includes absolutely, you know, idiopathic arthritis, it's very painful. Let's just reduce the pain and the swelling and let's keep function for this child. I'll multi-select. What might you anticipate for a child diagnosed with JIA? What assessments are you going to see? So we're going to have that joint problem. We're going to, in the morning or when we've been sitting a long time, try to get up. That's that difficulty, that stiffness. Remember that uveitis? That's the eyes turn red. That's why they need eye exams. And facial rash is lupus. What is cerebral palsy? It's all about body movement and muscle coordination. It just, the muscles don't do what you want them to do. A multi. What are signs and symptoms of spastic cerebral palsy? So it's a little bit of everything. You're going to have poor posture, hypertonicity, poor fine motor, poor gross motor, poor balance, all of the above. Yes, very good. A multi. When feeding a child with cerebral palsy, what's important to remember? Remember, I told you one of the things with cerebral palsy is their problems with muscles. And always you have to remember safety with a child with cerebral palsy, whether we're feeding them or just playing toys with them. All right. So remember, if we're feeding a child with cerebral palsy, their muscles don't work in the right manner. So keep the head of the bed elevated, prevent those aspirations. Give that child extra time. They're going to take time to be able to chew and to swallow those things, okay? You would actually thicken fluids or liquids on this child. They're easy to tolerate than thin ones. And you don't have to just feed them gastrostomy tubes. You try to feed them food if you can. Give them that oral pleasure, that taste. A myelomeningocele. What is it? So, a myelomeningocele is when the spinal cord, meninges, and the nerves are pulled up and outside of the bottom of the back or the lumbar area, and it just sits there. And again, you've pulled nerves up and spinal cord. So, we're all worried about nerve health here. I'm not dying. What can help a child with lupus prevent exasperations? So again, sunlight is not good on lupus. It doesn't like it. I guess with the skin conditions and rashes, wear sun cream and decrease that exposure. Also, these are children, they're immunosuppressed. Anytime they do any procedure like dental extractions, they do need a prophylactic antibiotic to prevent problems. Infants with a myelomeningocele demonstrate what? Remember, it's the meninges and the spinal cord and nerves are pulled up and outside the lower back. So you have damaged nerves there. So motor and sensory impairments, absolutely good. Myelomeningocele have decreased motor and sensations of lower extremities. The nurse should monitor closely what? What are you concerned about with a myelomeningocele? That nerve things, right? So the big thing that we really need to be concerned about is urinary retention, also constipation, right? Because you don't have the feeling there, you don't feel it. So it really needs to be monitored closely. A key feature of Duchenne muscular dystrophy is remember Duchenne, boys, ages 3 around 7 years old, we figure it out. And it comes from mommy's gene, the X gene. And it is basically a progressive muscle wastage. And we're concerned about the heart muscle and the diaphragm, which usually fail when they're teenagers. One of the procedures that a child with possible Duchenne's may need to diagnose the condition is what? What do we do to help diagnose this? Remember, Duchenne has to do with progressive muscle weakness. So it's called an EMG, electromyography. Remember, once they are done with this exam, it's like they ran a marathon. They're going to hurt. So make sure you give them something, Tylenol, Motrin, something. How is Duchenne muscular dystrophy inherited? And it's X-linked recessive. It comes from mommy. Yes, it does. In caring for a patient with Guillain-Barré, the priority concern is what? What's your biggest worry with Guillain-Barré? It's all about airway. I mean, it starts out with the shuffling feet, then it gets into incontinence and maybe constipation or, even losing control of the bowels. But then it hits the respiratory center, it hits the diaphragm. So again, it's all about maintaining airway. Without airway, nothing else matters. For a patient suffering with Guillain-Barré, they would complain of weakness that was what? And we call it ascending. What's worse than awakening? That is your JIA, that's your arthritis. You're stiff when you wake up. Guillain-Barré is just weakness. It starts with the feet. So it ascends or goes up when it hits the diaphragm. That's when you're in trouble. A multi. Treatment for Guillain-Barré include so IVIG and respiratory for sure. Know that Guillain-Barré, we might give IVIG because we're boosting an immune system. It's a virus of some sort. We don't know what it is, so it's not antibiotic. Would we be giving heparin It's not treatment, but it's a preventative of blood clots. We might give it for that, but it's not the treatment of Guillain-Barré. It's all about IVIG and respiratory support. What type of cerebral palsy causes hypertonicity and poor fine motor skills? When we think of cerebral palsy, this is what we usually think of. And it's called spastic cerebral palsy. This is the one where they're very spastic and, they really need help moving and maybe a wheelchair or a walker or help eating. That's usually what we think of. What priority action should a nurse take to a patient with suspected spinal cord injury? And again, anytime you suspect that that spinal cord's been injured, it's all about immobilizing it. I would rather put a collar on and tape them to a board and take it off later and make sure that they're okay than not having them taped down and then they have an injury where they get paralysis. So again, I know some kids don't like it, but we can help a child. You should get a tetanus shot every how many years? Since I started nursing, it's changed a few times for me. So it's actually every 10 years. We used to do it every 2 years. Then we went to every 5 years. Now we're doing it every 10 years. So it's amazing that they feel that that's where it needs to be now. It's always going to change. They're always upgrading. So which is a symptom of tetanus? It's all about that lockjaw, isn't it? Because it locks the jaw, it moves, and it protects it takes and it smooshes in all the muscles, and then you can't breathe. And that's that lockjaw. And that's why we intubate them, or we put them on a tracheostomy, and we paralyze and sedate them and try to get all those muscles relaxed, just to give them an airway. Let's see how we did today. Number 3. May, good job, May. Number 2, Lizzie. Good job, Lizzie. Number 1, drum roll, please. Kayla. Good job, Kayla. And a Brittany and Ashabat. Oh, look at that. So this is the end of today. I think we got all the stuff here for you. I will be sending you the Calculate with Confidence form again, just to make sure you have it. Somebody said it didn't work. So I'll be sending it with you that you can have. Remember, we are doing reviews this week for exams. I do mine tomorrow at 4 o'clock. Yes, it's recorded. Yes, I will post it. And it will be in one announcement for all of the reviews. So you don't have to look in 7 different places, because that's ridiculous. So one place, everything's there. You've got all the Kahoots. You've got all the everything you need. Now, what I sent you are big Kahoots. You also have on your weekly ones the one that divides every chapter. So I would go through those. All right, just to tell you, those are the ones to go through. Any questions by anybody? Bye, guys. It's been a pleasure again.
I got a question for you.
Sure.